Good afternoon, and thank you for attending our webinar today. TAD was founded to provide the option for home health billing agencies to outsource their billing and accounting and consulting services to industry experts. Our billing specialists, accountants, and CPAs have dedicated themselves to the home care industry and bring our knowledge to you today. My name is Mary Reyes. I'm the Director of Operations at TAD. I've been with TAD for over 17 years and will be presenting today's webinar. Joining me today is Danelle Leon. Danelle has over 14 years experience in home care billing and has been with TAD for over 6 years. Danelle has experience working with many different softwares and can troubleshoot many problem claims. We have a lot to share with you today, so we're going to get started. All of our attendees are in listen-only mode, but please feel free to send your questions to us throughout the webinar via the question box on the right-hand side of your screen. We'll answer those throughout the webinar as they pertain to the topics at hand. If we don't get to address your question at the time, please stay with us to the end, and we'll have a question and answer period at the end where we can address any questions that we may have missed throughout the webinar. At the end of the webinar, we will have our contact information posted, and you can reach out to us for further questions or would like to discuss our services. There will also be a brief questionnaire that will pop up when you log out, and we would appreciate it if you'd take a moment to let us know any feedback you have for us. So again, we're going to get started. Today we'll be talking about the basics of Medicare billing for home health agencies and how the new PDGM changes will impact that billing process. Our goal today is to provide a basic overview of the process that will enable you to review your own billing practices. This webinar is not intended to teach you how to bill. So the first thing we're going to discuss is the PPS type of billing. Medicare bills home care services in episodes. Episodic billing consists of 60-day period and is billed in two parts, a RAP, a request for anticipated payment, and a final claim or end of episode claim. Each period of care has a RAP and a final. Currently, payments are based on the OASIS assessment that is completed upon the admission of the patients and every recertification period until the patient is discharged from your services. But effective January 1st, 2020, the 60-day episode will be divided into two parts, two 30-day periods of care. Under the new patient-driven grouping model, or PDGM, the OASIS will still be required for each 60-day episode, but the payments will be used and billed under the new PDGM groups in two sections, 30-day periods under that episode. So first we're going to talk about the RAPs. They're submitted at the beginning of each of their agencies, each period of care. The agency receives 50 or 60% of the PDGM value or HHRG value, depending on whether it's the first period of in your start of care episode. The final claims are submitted after the period has ended, and the claims include all of the actual services that were provided for that patient. RAPs are submitted at the beginning of the episode when you have the following items completed: verbal order from your physicians, first billable visit is completed, and a locked OASIS. Your plan of care must be submitted to your physician for signatures. They don't have to be returned with the signature. That's part of your final claim process. Once the RAP is processed by your agency, the agency becomes the agency of record on the common working file. The common working file is how the other agencies know that you're treating that patient. To avoid overlapping with other agencies, verify your patient information in the common working file by reviewing the eligibility and making sure that there's no other episodes there, and bill your RAP as soon as possible so that you can become the agency of record. The period of care lasts for 30 days, and when you have another 60 days to submit your final claim. If you fail to meet this deadline with Medicare, Medicare will reverse the RAP payment and you will need to reprocess that RAP before the final will be processed. Note that this is a 90-day period now instead of a 120-day period. Under the current system, you had submit your RAP, you treated for 60 days and had 60 days to submit your final bill. So you had 120 days to obtain all of your doctor's orders and all of your documentation. You still have the 60 days after the period ends, but your period is only 30 days. So you only have 90 days from the opening of the episode for you to obtain that information for your final billing. RAPs pay approximately 5 to 10 days, but that will vary depending on the MAC, Medicare administrative contractor that you use. Also, we anticipate that this might slow down some come January 1st as Medicare switches over to the PDGM. So another impact of PDGM on the RAP is that Medicare is in the process of trying to reduce or eliminate the RAP payments. The first series that they've talked about is if an agency was certified before December 31st, 2018, we currently do not anticipate that there will be any change. You'll still get the 60 or 50%. Agencies certified on or after January 1st, 2019, that's this year, you will no longer receive RAP payments when you process your RAP billing after January 1st. The final rule has not yet been published. It's still unknown whether this is exactly what's going to happen. They still are discussing the RAPs as far as the existing agencies, what's going to happen with that. I anticipate there may be another change. If this is of concern of yours, I'd recommend signing up for our November 14th webinar. It's called Industry Updates. Dan Parker and Tonya Elkins will be performing that webinar, and they will be discussing the final rule and how that's going to impact the agencies going in 2020 and prior years and future years. So again, that webinar will have, hopefully that final rule will be published and will have all very pertinent information and very accurate and timely information. But as it stands right now, this is what we would anticipate. Final claims. There are several requirements that need to be met before submitting your final claim. You need to have your face-to-face documentation returned and signed by the physicians for your initial episode. OASIS assessments must be filed and accepted in the repository. Plan of cares, your 485s need, and all the other orders must be signed by the physicians and part of the chart. All other visits and documentation must be completed. Medicare does have a edit that cross-references the OASIS information and the final claims, and they are currently suspending payment on those finals until if there is not an OASIS in an accepted format at the repository. So it's important to make sure all that documentation is complete. Claims include all billable visits and non-routine medical supplies. If you have late visits are identified after the final claim is billed, you can adjust the claim. We always recommend that you have all of your information prior to billing that final, but it is possible to make those adjustments. You also want to make sure that you're billing what is representative in the chart. You don't want to bill for services that are not documented. Submit the final claim as soon as possible after discharge or the end of period of care. Again, that will prevent you from losing or having the RAPs reversed and then having to reprocess if you do it within that 60-day period. Final claims are adjudicated between 14 and 28 days, but again, it can vary by your MAC. And again, we anticipate there might be some delays in payment as the PDGM conversion starts. There is a 1-year filing limit from end date for Medicare. Types of episodes under PPS. This is remaining the same. Your episode is still 60 days. Just the billing portion of that has changed. A full episode is the 60 days. covered by your OASIS assessment. The period of care is considered a full period of care for those 30-day periods. A PEP, or a partial episode payment, is an episode where you do not provide care for the full 30 days, 60 or 30 days. Once you discharge or transfer a patient and that patient is readmitted by you or another agency during that period of care, it will be considered a partial episode. Medicare won't pay for duplication of services for two different providers. So what will happen is they'll calculate a daily rate and multiply that by the days that they were under your service versus the other agency. And then there is also a LUPA payment, a low utilization adjustment, payment adjustment. Currently, a LUPA is considered in that 60-day period of care. If you do 4 or less visits, it qualifies for a LUPA. The LUPA is then calculated on a reimbursement of a per visit rate. Under PDGM, that's changing. Because it's a 30-day period of care, the LUPAs can be triggered now by as few as 2 visits or as many as 6, depending on the PDGM group that the patient qualifies for. LUPAs can be submitted with or without a RAP. However, when you submit your final LUPA claim, it must still meet all of the requirements for the final claim. You must have all your documentation, the order signed, and all of that. And if you're not familiar with the review choice demonstration that's going on, or the pre-claim review process that is happening, there is an impact of LUPAs that will be taken into effect January 1st. The no-RAP LUPA currently, if you're under the review choice demonstration, is not required to have the UTN number for the pre-claim review. The regions currently participating in the review choice, or PCR, are Illinois. They started in June. Ohio started at the end of September. And currently, Texas is supposed to start the beginning of December. Texas may be delayed, but as of right now, today's notification, we're anticipating December 2nd to be the start date of that. The other 2 states, Florida and North Carolina, they're pausing the implementation of the review choice until after PDGM transition. So it will be late, probably after March or later, depending on if they delay Texas as well. Could be even later. But that is happening where they have to submit their documentations prior to submitting the final claim and get a UTN number that goes on the claim, like a authorization number for Medicare. PPS has many different types of bill that goes on the claim. You need to understand these types of bill if you're reading your remittance advices to indicate what type of payment is made to you. One of the first ones is a 322. That indicates that this is a RAP claim that was paid. A 328 is a reversal or a payment recoupment. It's a reversal of a previous payment. It's used when you're billing a final claim, when Medicare reverses the RAP and then pays the final claim. If they're doing a RAP recoupment because the final claim was not processed, it would also be as a 328. 327 is an adjusted final claim. This adjustment is agency initiated. So you as an agency, if you needed to adjust that claim and put those couple of extra visits on the claim form, you would submit it as a 327. A 329 is a final claim or a no RAP LUPA. This is initial final claim that has gone out. A 327 would be adjusting this 329 claim. A 320 is a denial. Then we have a 32G and a 32I. Both of these are Medicare adjustments, and this is where the adjustment was initiated by Medicare. So, for example, would be the PEP or the partial episode payment that we were just talking about. You may have submitted your final claim and received full payment, but then that patient went on service with another agency, and when they finally bill their claim, that's going to be what triggers you to be a partial payment. So then Medicare would go in and adjust your payment, and you would see it on your remittance advice either as a 32G or a 32I. Non-routine medical supplies. You still are required to report non-routine medical supplies on your final claims. Home care billing does not require you to list individual supplies. You can bundle the charges under one of two revenue codes. The 270 general non-routine supplies, or 623 is for wound care supplies. There is a change about the supplies under the PDGM. It's not one that you're going to see on the claim form or in the reporting on your end. It's how they reimburse, the calculation reimbursement is for the supplies. Currently under the HERG, you have the whole case mix, weight, and everything else in the calculation, and then the supplies are an add-on to each of the individual HERG amounts. Under PDGM, those supplies are incorporated into the base payments, so it's not as a separate category. So if we just want to touch a little bit on how those rates are determined under the PDGM, they were using cost report data and Medicare claims to create that base cost of services. The advantage of this is that under the cost report cost per visit calculation, they take into consideration all of the administrative costs of servicing these patients. So your administrative personnel, your rent, your lights, all of the things to run your agency that are allowable costs on the Medicare cost report are being used as the cost that they were using under these terminations when they were determining the new reimbursement rates. And that leads us a little bit more into the PDGM, patient-driven grouping model. I want to touch base on how they are using these new PDGM model, what components are being used to make that determination. So effective January 1st, 2020, Medicare is changing to this new pricing model. There are 4 components to the grouping that will be used to determine the reimbursement amounts. Under the current method, we have 153 case mix groupings. Under PDGM, there's going to be 432 possible case mix groups. So that's a significant increase in the different categories that your patients can fall into. The components that are being used are the source of admission and timing, clinical groupings, functional impairment level, and comorbidity adjustments. This is a diagram of how the different components relate to each other. The patient-driven grouping model. So first in the top is the blue, admission source and timing. There are basically 4 different options. Your admission source is one or the other, community or institutional, and your timing is late or early. Your first episode, your first 30-day period of care in your episode will be your early determination. All other subsequent periods of care will be late. The institutional or community depends on where your patient was residing in the 14 days prior to the home health admission. So if they were coming from a facility, then it would be an institution. If they were just coming from your doctor's office and they're recommending home care, then it would be community. The home health agency has the option to include an occurrence code on the claim form to identify an institutional admission source. If the admission source is a Medicare facility, Medicare will have this information and will adjust the claims accordingly if you do not code it appropriately. But it's best to include this information at the time of billing to reduce Medicare adjustments. If the admission source is not a Medicare facility, for example, a veterans administrative facility, the only way for Medicare to obtain that institutional value is from the claim information on your claim form. Both the admission date, discharge date, and that occurrence code have to be on the claim for you to qualify as an institutional admission. Clinical groupings, that's the area in the orange on this screen. These groupings represent the reason for the primary home care services. It's the principal diagnosis. There are 12 different clinical groupings that will fall into place. The musculoskeletal rehab, neuro or stroke rehab, wounds, complex nursing interventions, behavioral care, and then under the medication management, there are 7 subcategories for those. Surgical, cardiac, endocrine, and GI, various other subgroups. Then in the green is the functional impairment level. That's either low, medium, or high. And that information is what comes from the OASIS. There are questions on the OASIS that will be used to determine whether it's low, medium, or high. And then your comorbidity adjustments. This is the secondary diagnosis is reported on the claim form. And then you have 3 different options here. There's none or no comorbidity, low or high. And that all depends on the comorbidity diagnoses that are put on the claim form. If you're unfamiliar with some of these or you want more information on how these parts interact and how you can look at your current patient mix and see how that's determined, CMS has a PDGM grouper tool available on the website. I would recommend that you download that and start becoming familiar with it. It could show you how the different diagnoses work together to create your new case mix weights. Also, within that grouper model, there is a tab on it's an interactive worksheet, and one of the tabs will indicate the different LUPA thresholds. So once you have a PDGM code, you can go to that page on the tab and it'll tell you whether 6 visits is a LUPA or 2 visits is a LUPA. So it provides a lot of information, and I would recommend going to the cms.gov website. And if you go to the cms.gov website and in the search type in PDGM, it'll bring you to the resource page, and there's you can download the grouper tool. There's also 2 webinars they put on last year that were very, very informative. One was dated February and one was dated in August, and both of them go into extreme detail about the changes in PDGM. And if you're needing more education, I would highly recommend them. They have them available pre-recorded through the website PDGM resource page.
Mary, I have a question. If a patient was coming from a nursing home, would that be considered institutional or community?
If they're residing in the nursing home and that's their place of residency, it would be community. If it was a nursing home due to prescription from a doctor for some type of like a rehab facility or something along that line, then it would be institutional. But just a straight nursing facility, it would be, if that's where the patient resides, it would be community.
Thank you.
Thank you. Okay, it's a lot of information that we've put together and how you bill it in 2 different parts of the claim, a wrap and a final. But how do you bill it? How do you get the information to Medicare to get reimbursed? Currently, Medicare will only accept electronic format of their claims. They will not take paper copies. So you can do that in one of 2 ways. You can do the DDE or direct data entry. And with the direct data entry, you have to have access to the FIS system. You manually type in the information into their system. There's some drawbacks to that though. You're limited to your staff's knowledge. Are they familiar with all the Medicare requirements? Are they putting the right information in the right fields? That kind of thing. It's also time consuming, and it opens you up for human error, transpositional errors, neglecting to fill out the right codes or the right field. The other, and what I find even worse, because you could have the best typist in the world typing in all this information, but what I don't like about DDE is there's no data accumulation opportunity. And what I mean by that is there's no reports. You don't get a summary of your patients. Every time if you have the same patient and you readmit them, you have to put all that demographic information in again and again and again. And of course, as you know, with the Medicare requires your Medicare cost report at the end of the year. And the Medicare cost report, you have to have statistical information as well as the financial information. So under DDE, you would have to do all of that tracking under some other form of method, either Excel spreadsheets or some other type of data accumulation system. So the next way is through a management system. This is what our preferred and recommended method is, because there's a lot of different software companies out there, and a lot of them do a very, very good job. A couple of things that they can help you with is they can help you in maintaining your clinical information. They can also, a lot of them have different bells and whistles on there that will help you be compliant, so that you can't submit a claim unless you have all of your orders in, unless you have all of that data marked. And if you're using the system the way it's designed, it can help you stay in compliance. It also allows you to batch bill. When you're billing in a batch, you can submit a lot more claims activity. You get confirmation reports that the claims were received. You can also, a lot of softwares have a good financial and data accumulation information, which you can get a series of different reports out of the system. So we recommend a software company if you haven't made one as well. Haven't purchased one yet. With the electronic billing, basically you're creating the claims within the management software and then submitting those batch files to your Mac for processing. Some softwares will transmit those files for you. A lot of them will tell you how easy it is to bill in their software. And what they're saying is that the creation of the batch files within the software is an easy process. And this may be true. However, I have yet to find a software company that confirms, or a software that confirms the receipt of the file, receives the payments for denial, corrects the claims, spends time on the phone when necessary to follow up on unpaid claims, and all of those day-to-day interactions that have to happen. A good management system is vital to accumulate the data and meet all the requirements necessary for staying in Medicare regulation compliances. However, it doesn't replace having an experienced biller or a billing company like TAD on your side. Here at TAD, we have experienced billers, and we work with many different management systems, and we even do DDE for our clients. We would be happy to talk to you about our services. If you're interested in more information, you can request a call when you complete the survey at the end of the webinar, or you can also go to our website at any time and request additional information. Electronic billing also allows you to receive confirmation of reports, and that you can use it if you need to dispute timely filing. And then you can also have different types of accumulated reports. Like I said, management system, you've got the data, now what do you do with the data? And here are some of the reports that we like to see for our clients that we use on a regular basis. One of the first ones is an unbilled report. Your software may have these available. It may not look exactly like this, or it might, depending on the software company you have. But what this does is this report allows us to look at each episode that has not been billed, ones that need wraps or ones that need final billing. And this also has a nice little grid that tells you what's wrong with the claim. Why hasn't it been billed? What is still pending? So in this situation, if we look at the wraps, the very first patient is Albus Dumbledore. and we're not able to bill that wrap because the OASIS is not completed. And if you see the next two, Harry and Hermione, they are ready for billing. They've got both check marks. But Ron, the last one, we're not able to bill Ron because there's no visit that's been confirmed for that wrap to be processed. If you look under at the final claims needed, you can see, again, Albus Dumbledore cannot be billed because his wrap is not done and there are no orders signed. Harry and Hermione are good to go. Ron cannot because he doesn't have visits and he doesn't have orders. So this is a nice tool to help your staff and your QA staff to make sure that your billing is going out timely. What do you need to fix? What do you need to identify? Because as we move into the PDGM and the 30-day billing periods, timely billing is going to become more and more critical for your cash flow. Another report that we like to use here at TAD is the invoice summary report. Again, your report coming out of your software may be different than this, but what I do like to see on this is the patient's name, what insurance it is, what period of care it is, episode or period of care, whether it's a wrap or a final, and what amount you expect to receive in payment. In this particular report, we have two payment columns. We have the HERG amount and we have the expected payment. The difference between these two is that the HERG amount is the amount that we expect for the entire episode or period of care in reimbursement. Both parts, wrap and final. But in the last column, the expected payment, that's how much we actually expect to be paid on this particular claim. So in this situation, these three patients are going to generate $6,000 worth of revenue, but currently we just billed $2,900 that we expect to be paid within the next 30 days. So we've showed you an unbilled report, one that is active report, your activity, and then we have the accounts receivable report. The accounts receivable report is extremely useful if it's maintained. What I like to see in an accounts receivable report is being able to sort it by payers. You want to see your patient detail, you want to see your episode or period of care detail, and then you want to see the outstanding payments. In this one, we have a couple extra columns that I like to see, the claim date and then the billing period start and end dates. The difference there, the claim date is the date that the claim was generated and processed to your MAC or payer source, and then the billing period, start of care, is the period of services, the service period that's covered on that claim. So if you don't know or don't have either of those numbers or only have one of those dates, you're not don't have the full picture of the claim. If you only have the claim sent date, it could be a claim that just sent yesterday, so it's a very current claim, but it could have been for services that were generated in January, which is a very old claim. So accounts receivable, you want to be able to distinguish the difference between a processing date and a period date. The accounts receivable summarizes claims that have been processed to the payers and not been paid yet. But receivables is only as good as the payment portion is of your software as well. We have a lot of clients that come to us and don't post their payments into their system, which deprives them of a very useful tool in the accounts receivable report. So that's the majority of Medicare. As we know, there are other insurance carriers out there that we do business with. There's the Medicare Advantage and Replacement plans. They are billed episodically like Medicare. You must meet all of the Medicare requirements, but you also must meet their requirements. They do have the ability to require authorizations. So as you start taking on these payers, you want to make sure that you're billing in their compliance as well as Medicare's compliance. There are also commercial insurances that are billed by the visit. Again, you must meet those payers' requirements. Quite often they require authorization, and they often have shorter filing limits. They may not be a year. They may only be 45 days. They may be 6 months. So you want to make sure as you're taking on any new payer sources besides Medicare that you are aware of all of those filing requirements. We also expect the Medicare replacement and Advantage plans to move into the PDGM pricing and billing requirements. It's important to confirm that with your payers to determine what time frame they are going to be implementing those changeover as well. So we've covered a lot of billing topics. I just want you to be aware that we have other webinar topics available. Our next one, as I mentioned, is the industry updates. That's going to be November 14th. I think it's very important that all of you sign up for that one or listen to it, because it's going to have, hopefully the information of the final rule will be published and that will be discussed, as well as any other proposed rules that are going to be coming down in the future. We also have accounting and tax issues. That one's going to be, is currently scheduled for December. And we have these other topics, insurance verification and eligibility, intake footsteps, outliers, the good, the bad, and the ugly, Medicare cost report and PS&R, understanding Medicare remittance advices, the ins and outs of accounts receivable, billing at a glance, and soon we'll have one that's when claims don't pay. We advertise these on our website. We also send out invitations when they're scheduled. It's important to monitor our website for these if you're interested in these topics. A lot of them are being in the process of being updated for the new changes that are coming down. So after January, all of these will be refreshed and new. We're also moving into the pre-recorded arena where you can listen to our webinars on YouTube. As they become available, we'll be making those available on the YouTube channels. So if you're interested in any of those topics, we'd be happy for you to participate in those webinars.
Mary, do you think with the commercial and the Medicare Advantage plans that they'll jump in right away with the PDGM?
I would anticipate that they would, simply because their payments are based on the same model that Medicare does. Currently, they're paying at the HHRG grouper rates. So when they submit the claims and data to Medicare, I would anticipate that it would just be a conversion over to them for the PDGM. It's the 30-day billing periods and the 60-day billing periods that I'm not sure what they're going to do. That's a good question, and each payer may be different. They may not have their software ready to accept a 30-day period of care, but a lot of them, have had over a year to get ready for it too. And most of these commercial payers, that is their business model prior to home care. In all other medical features, they either pay per diem or you bill for a 30-day period of care. So I would anticipate that move will be relatively quick.
Thank you.
So if there's any other questions, we'll be here for a few more minutes. If you have any other questions, I'd be happy to talk with that. Or here's all of our contact information. If you want to call me directly, you can reach me at this phone number, or you can send an email or go to our website and contact us that way. We'd be happy to talk with you further about services. As I mentioned earlier, our intent is not to teach you how to bill, but to give you information that will help you understand the billing process and to help you manage your billing practices. We know you work hard caring for your patients, and you deserve to be paid everything you're entitled to for the services you provide. Here at TAD, we've billed over 100 commercial insurances, state Medicaid programs, as well as Medicare. We have serviced over 300 home care agencies, so we know it's a complicated and ever-changing world in the home care billing. We hope you'll consider using TAD for your billing and accounting needs. If you're interested in more information, again, you can contact me with this information. And again, thank you for attending the webinar today. And please remember to complete the survey as it pops up after you've viewed the webinar. Thank you.